Hello guys, welcome to the third part of our high yield concept series, and in this part we will discuss the most high yield 50 concepts in the endocrine systems. Okay, Karim with you, and let's start. So the first high yield concept, and it's specifically in the embryology, is that we have two cysts that would happen in the neck most commonly. We have the thyroglossal cyst, which comes from the thyroid gland itself, and we have the pharyngeal cyst. Now the difference between them is two things. First is that the thyroglossal cyst is usually anterior to the neck, but the pharyngeal cyst is usually lateral to the neck. The second thing is that the thyroglossal cyst is somehow connected to the tongue into something or by something called the foramen cecum, and this is extremely important. Okay, so when you somehow protrude your tongue, the thyroglossal cyst will move up and down with protrusion of the tongue, and this is the second most high yield concept. Okay, so thyroglossal cyst is anterior and it's connected to the tongue by foramen cecum, and they usually ask about this concept. And the other thing is that pharyngeal cyst is usually a lateral mass and it doesn't move with the swallowing. The second concept is the histology of the adrenal gland. Now this is the adrenal medulla here. This is adrenal cortex and this is the adrenal medulla. And the way you remember it is by GFR. So zona glomerulosa, zona fasciculata, and zona reticularis. The second thing is that you have to remember which hormone is secreted by which zone. So the deeper the sweater, meaning at first it's usually something that absorbs salt. It's not sweet, so it's mineralocorticoids. Then after that you have cortisol, which will increase glucose, which can be considered a little bit sweet, right? Then at the last we have the sex hormones, which is the sweetest thing, right? So that's how you remember it. The deeper, the sweeter. Okay. Then we have the adrenal medulla, which has chromaffin cells, which secrete catecholamines. Okay. Now something that's very important is that this part here is the capsule. So don't count it from the zones, because some people will count the capsule as the zone. So they will say, okay, this is glomerulosa, this is fasciculata, this is reticularis. This is wrong. Okay. So don't count the capsule from the zones. Okay. The third important concept is that oxytocin and the antidiuretic hormones are synthesized from the hypothalamus, okay, from the paraventricular and the supraoptic nucleus, and they will be transferred from the hypothalamus to the posterior pituitary by a carrier, and this carrier is called neurophysin. This is very important. Another thing is that oxytocin acts through phospholipase C or IB3 or GQ or increased calcium, whatever you want to remember it. And this is very important because sometimes they will ask about the pathways. And what I have realized from the NBMEs is that this is the most common hormone that they ask about the pathway of it, which is IB3 GQ phospholipase C. Okay, this is extremely high yield. Another thing is the function. It stimulates milk letdown, not milk production. And it also increases uterine contraction to help in pregnancy, not decrease. Okay. The fourth high yield concept is that anything that will work on cyclic GMP, or anything that will increase nitric oxide or nitrates in general, or phosphodiesterase inhibitors in general, all of these things will cause the same outcome, which is vasodilation. This is very important. Okay. So for example, when they tell you nitric oxide or nitrate, which increase nitric oxide, will act on which of the following pathway? And the answer is it's cyclic GMP. And it will do what? It will do vasodilation. This is very important. Okay. So when they ask you about the pathways or the receptors or anything related to the pathway receptors, whenever you see that this drug causes vasodilation, you just choose cyclic GMP. Okay. This is a very easy way to remember the pathways. Okay. Another thing is how the hormones act. So here's the thing. If the hormone cannot pass through the membrane, so it will act on the cell membrane itself. But if it can pass, then it will act either in the cytoplasm or the nucleus. Okay. Now any hormone that's lipid soluble, like steroids, cortisol, mineralocorticoids, sex hormone, will usually pass through the membrane, so they will act on the cytoplasm. Okay. Vitamin A is also lipid soluble, right? Isn't the lipid soluble vitamins are A, D, E, K? So sometimes they will ask about vitamin A, and it will also act into or inside the cell. The thyroid hormone will also act inside the cell, specifically in the nucleus itself, and the zinc. Zinc is also important. We have something called zinc fingers that change the DNA, and it will cause something related to the DNA and the transcription pathway. Okay, so any hormone that's lipid soluble will act inside the cell. Other hormones will act on the cell membrane, like glucagon, like epinephrine. Okay. The next high yield concept is that diabetes insipidus can either be nephrogenic or central. So what is diabetes insipidus? It's when you urinate too much, but it's not diabetes mellitus. Okay, you urinate too much, but it's not diabetes mellitus. Okay, and diabetes insipidus usually happens from a problem in the ADH, because if you remember, ADH absorb water. So if you don't absorb water in the kidney, all this water will go into the urine, so you will urinate too much. Okay, now there is two problems that can cause problem in the ADH. Either you don't secrete enough ADH, which is called central diabetes insipidus, meaning you have low ADH. This can be either from trauma or problem in general in either the posterior pituitary, then it would be reversible, or the hypothalamus, then it would be permanent. And the reason for that is that the hypothalamus is the one that synthesizes the ADH, but the posterior pituitary just stores the ADH. So any problem in the factory itself will cause permanent diabetes insipidus. Okay, and it will be corrected if you give ADH analog, right? Because if the problem is low ADH, just to give another ADH or synthetic ADH, then the problem would be corrected. Okay. Now the second problem is that we have normal ADH, but it cannot act on the receptors. The receptors are called aquaporine. Aquaporine. Aqua means water, porine means pores. And it makes sense. There is pores that will somehow allow the water to be absorbed, okay, by ADH. So nephrogenic would be a problem in this receptors itself. Now the most famous drug that will cause the symptom is lithium, and it will not be corrected by giving ADH because the problem is in the receptor. So no matter how much ADH you give, it will not be corrected. Okay. Now I have seen some question on the NB means asking about what's the treatment for nephrogenic, and the answer was thiazide diuretics. Thiazide diuretics. Okay. Okay. Now, extremely high yield concept is to differentiate between nephrogenic diabetes insipidus and the syndrome of inappropriate antidiuretic hormone, because on both of them you will see high ADH. But the difference is that in nephrogenic there is high ADH, but it cannot do its function. But in CIADH there is high ADH, and this high ADH is doing its function, absorbing a lot of water in the serum. Okay. Now, what are the causes of CIADH? You have carbamazepine, SSRIs, and you have also small cell lung cancer. Okay. Now the difference between them is that in CIADH the ADH is working. Okay, so you will see that there is hyponatremia in the blood serum and the hyperosmolarity in the urine. But this is the opposite of nephrogenic diabetes insipidus, which you would see hypernatremia in the serum and the hypoosmolarity in the urine. So take care of this difference here. Okay. The next high yield concept is that dopamine is the only hormone that's secreted from the hypothalamus, and it will inhibit another hormone in the pituitary, which is prolactin. So dopamine inhibits prolactin. So if there is damage to the pituitary stalk or stick, which connect the hypothalamus to the anterior pituitary, the only hormone that will increase in its level will be prolactin, because it will lose the inhibitory signals from dopamine. Okay, this is important. Okay, the next important concept is the commonest type of pituitary adenoma in general is prolactinoma. Now, pituitary adenoma will cause this triad of headache, bitemporal hemianopsia, because usually it compresses the optic chiasm, which receives the temporal pathways, and also it will sometimes cause galactorrhea if it's prolactinoma, because this is the most common type. Okay. Now the treatment of prolactinoma will be bromocriptine and cabergoline, which are dopamine agonists. Isn't prolactinoma a lot of prolactin? Then just give dopamine agonist, so it would inhibit all this prolactin. Okay, this is also important. Okay, another high yield concept is that the high yield hypothyroidism manifestations that you need to know about is brittle hair and the high LDL. The reason I presented high LDL here, because we remember that hypothyroidism will cause low in everything. It will cause constipation, it will cause bradycardia, right? It will cause cold intolerance, right? It will cause low basal metabolic rate. But the only thing that will be high is the LDL, okay? The lipoprotein lipase, okay? Now, another important thing is that hypothyroidism can also cause muscle weakness and a delayed deep tendon reflex, deep tendon reflex, and it can increase creatine kinase level. Okay. The second concept is that whenever you see hyperthyroidism with proptosis and the exophthalmos, this is always Graves' disease. Now, the way they can ask you about Graves' disease is which type of hypersensitivity it is. It's type 2 hypersensitivity because there is antibodies that activate the TSH receptors. Okay. And another thing is that sometimes they will show you the histology instead of giving you the symptoms. And in the histology, what you would see is colloids, a lot of colloids here, because the thyroid gland is working too much. Okay. The other concept is that whenever you see hyper or hypothyroidism, sometimes it will be hyperthyroidism, it will be early and rare, and sometimes you will see hypothyroidism, but this hyper will not be associated with proptosis, and you will see painless thyroid swelling. Then it's always Hashimoto thyroiditis. Okay, so whenever you see hyper but without proptosis, or hypothyroidism with painless, not painful thyroid, then it's always Hashimoto thyroiditis, which is also another autoimmune disease, but it's from T cell infiltration. So you would see lymphocytic infiltration, you would see something called Hersel cells, and you would see germinal centers. These are the germinal centers. They are made of B cells, by the way, and they can cause increased risk of lymphoma. Because whenever we have a tissue in a place that it's not supposed to be, you will always have increased risk of malignancy. For example, you are not supposed to see B cells here, right? So you will have increased risk of malignancy here, okay? There is increased risk of malignancy. Now, if you see the same symptoms, but after pregnancy, then it's called the postpartum thyroiditis, which is subtype of Hashimoto thyroiditis, okay? Another thing is the difference between Hashimoto and the Graves. We said the first difference is proptosis, right? The second difference is that in Hashimoto, you will see antimicrosomal antibodies or antithyroid peroxidase antibodies or antithyroglobulin antibodies, okay? And you will see decreased iodine uptake in the cell, even in hyperthyroidism, because the thyroid gland have been destroyed, so it's not working, so it doesn't take any iodine. On the other hand, in Graves, it will be mostly anti-TSH receptor antibodies only, and you will see increased iodine uptake, meaning that the thyroid gland is working too much and it's absorbing too much iodine, so it can increase its thyroid hormone synthesis. Okay. The next concept is that whenever you see a person with viral infection plus hypo or hyperthyroidism, but with painful thyroid, extremely high heat, whenever you see painful thyroid or tender thyroid gland, this is always called dequervain thyroiditis, which is also called subacute granulomatous thyroiditis. Okay. Now, dequervain, you always remember that dequervain will present with pain. And in the histology, you will see granuloma because it's called subacute granulomatous thyroiditis. Okay. Now, remember what other granulomas you can see. In general, in step 1, you can see also granuloma in sarcoidosis. You can see also granuloma in Crohn's disease. This would be non-caseating granuloma. And of course, the caseating one will be TB. Okay. The next concept, when you see a thyroid problem and hard as rock thyroid, not firm, but hard as rock, so it's extremely hard, then it would be always Reidel thyroiditis. If it's in young person, Reidel thyroiditis is usually fibrosis in the thyroid gland. And it's associated with a syndrome called IgG4 syndrome. Just remember this name, okay? But if you see it in an older person with weight loss, with night sweating, whatever, then it's aplastic carcinoma, which is a poor prognostic type of thyroid cancer. Okay. The next concept is that hypothyroidism in newborns will always be associated with other symptoms that you usually see in adults. For example, you would see umbilical hernia, you can see jaundice, you can see macroglossia, enlarged tongue, okay? And you would see abnormal facial features, okay? This is different from what you see in hypothyroidism in adults, okay? And this would be called cretinism, okay? Jaundice, macroglossia, umbilical hernia. Now, the most common cause of hypothyroidism in kids is thyroid genesis, meaning malformation or abnormal formation of the thyroid gland. Not hormone problems, but thyroid itself, the thyroid tissue itself has not been formed well, okay? The next concept is that lithium and amiodarone are high yield drugs that can cause either hypo or hyperthyroidism. Just remember that iode here, so it means it has iode on it, so it can mess up with the thyroid tissue, okay? And this is also important, okay? Now we have a disease called, or not a disease, but just a state called euthyroid sick syndrome. It will happen in critically ill people, and you would see normal TSH, normal T4, but you will see something called the reverse T3. It will be high, and the T3 itself will be low. So just remember, it will have high reverse T3 and low T3 itself, okay? Sometimes they will ask about what happened in the thyroid hormone in pregnancy. So what happened is that pregnancy usually increases thyroid binding globin. Now thyroid binding globin will usually cause increase in the total B4, but it will cause normal free T4 and T3. And the reason for that is thyroid binding globin usually increases the total thyroid count, because when there is a lot of thyroid binding globin binding to all this free thyroid, it will cause increase in the total, but the free will normalize afterwards. So whatever you need to remember, just remember that estrogen in pregnancy will increase thyroid binding globin, which will cause increase in total T4, but no change in the TSH or the free T4. So the only change will be total T4. Now if we know that, then we know that thyroid binding globin deficiency will decrease the total T4, but it will cause normal T4, TSH, T3, okay? So just remember that T with thyroid binding globin always affects the total thyroid, not the free thyroid, okay? So high TBG in pregnancy will increase the total thyroid, low TBG deficiency will cause decrease in the total thyroid, okay? Now how do you treat hypothyroidism? You treat it by levothyroxine, and the way levothyroxine works is that it's a synthetic T4, and it will be converted to T3 in the body, okay? Now sometimes they will ask about the arrows. So T4 will be high when you give it, T3 will also be high because it will be converted to T3, but TSH will be low by a negative feedback, okay? This is important. Now you need to know that T3 is more potent than T4 in general, but T4 has higher quantity than T3, and the T4 will be converted to T3 by something called 5-deiodinase, okay? And TSH is the most sensitive marker for thyroid problem. So whenever you suspect a thyroid problem in a patient, you order TSH first, okay? The next concept is that medullary thyroid carcinoma. This is the most high-yield thyroid cancer. It secretes calcitonin because it comes from the sheath cells, which secrete calcitonin, which do the opposite of parathyroid hormone, okay? It will usually decrease calcium in the blood. Now, what you would see, and extremely high yield, is the histology. You would see malignant cells sitting on amyloid stroma. So here this is malignant cells, and they are sitting on amyloid stroma. This amyloid stroma will be positive for Congo red stain, and they will appear as apple perfringi, in apple perfringi light, okay? This is important, okay? Or as apple perfringi in polarized light, okay? Now, it's important to know main syndromes in general. We have MIN1, MIN2A, MIN2B. If you need to remember MIN1, it's the primary MIN. So you would see tumors start with B, and they will be midline. So pituitary adenoma, primary hyperparathyroidism, parathyroid adenoma, and the pancreatic cancer, 3B, okay? Then you have MIN2A, MIN2B. Both of them will be associated with two medulla, medullary thyroid carcinoma and tumor in the adrenal medulla, which is pheochromocytoma. But the difference is that MIN2A will somehow take one of the specific features of MIN1, which is primary hyperparathyroidism. But MIN2B will be associated with mucosal neuroma in the tongue, and also Marfanoid habitus, meaning the person will have the same features as Marfan, tall and elongated fingers and extremely high height and things like that. Okay, the next concept is that BTU and methimazole are drugs that are used to treat hyperthyroidism. And in pregnancy, you will use BTU at the first trimester, and the methimazole in the second and third. And the reason of that is that methimazole, if you give it at the first trimester, you can cause aplasia cutis, something called aplasia cutis, meaning no skin at all in the scalp usually, okay? Now, both of them can cause a granulocytosis, decrease in the neutrophils. Both of them can cause hepatotoxicity also. And both of them will inhibit thyroid peroxidase, which is the most important enzyme to synthesize thyroid hormone in the tissue, okay? But the difference is that a BTU has another effect, which is that it will inhibit 5-deiodinase. It will inhibit the peripheral conversion of T4 to T3. So BTU has two functions, methimazole has only one, okay? And this is the important stuff about them. This is if they ask you about them, this would be the way they ask you about it. Okay. Another concept is that ovarian teratoma is usually a cancer that consists of normal tissue in the body. And one of the subtypes of it is a teratoma that secretes the thyroid hormone, and it will be called stroma ovari. And the histology of it is high yield. You will just see thyroid tissue in the ovarian gland or in the ovaries, and you are not supposed to see thyroid tissue in the ovaries, and this would be called stroma ovari. Okay. Vitamin D activation pathway is extremely high yield. You need to know that in the skin, by the use of ultraviolet rays, you will convert 7-dehydrocholecalciferol into vitamin D3, or it's called the cholecalciferol. It's important to know this name. Then this cholecalciferol in the liver, by the conversion by 25 hydroxylase, it will be converted to 25-OH vitamin D3. Then in the kidney, by the use of parathyroid hormone and the use of this enzyme, which is 1-alpha hydroxylase, the vitamin D, the 25-OH, will be converted to 125-OH, which is the active form of vitamin D. So if you have kidney problem or liver problem, or you are not exposed to sun continuously, then you can have an increased risk of vitamin D deficiency. Okay. The other thing is the effect of parathyroid hormone and the effect of vitamin D. So vitamin D usually absorb calcium and phosphorus from the intestine, okay? But parathyroid hormone, on the other hand, directly increase calcium only and decrease phosphorus, because parathyroid hormone usually comes to the kidney and it will increase calcium absorption in the distal convoluted tubule and decrease phosphorus absorption in the proximal convoluted tubules. So the way you think about it is that vitamin D will somehow love both calcium and phosphorus, but parathyroid hormone usually love calcium but hate phosphorus, okay? Another thing is that if parathyroid hormone is extremely high, it will somehow break down the bone and it will secrete calcium from it, okay? So this is the parathyroid hormone thing, okay? Now, how parathyroid hormone secrete calcium from the bone? It will bind to osteoblast and it will increase something called rank L. This rank L will bind to something called rank, okay? And they will activate the osteoclast, which will break down the bone and secrete calcium from it, okay? Now we have something called OBG. OBG usually protects the bone, and this thing is usually increased by estrogen. And that's why in menopause, when women lose estrogen, they will lose protrogen, so they will lose the protective effect of this OBG thing, and then they will have osteoporosis, okay? This is another thing that you can be familiar with, okay? Now, very high yield terminology is that rickets in kids or osteomalacia in adults are vitamin D deficiency, which is abnormal mineralization of calcium and phosphorus. But osteoporosis, on the other hand, is just a decreased bone density without mineralization itself, without calcium phosphorus affection, okay? So calcium and phosphorus will be normal, okay? And it happens usually because estrogen deficiency after menopause, because you will lose the OBG that protects the bone from being degraded by osteoclast. Okay. Now, another high yield concept is secondary hyperparathyroidism. So what is secondary hyperparathyroidism? It's a condition that happens in chronic kidney disease. Now, in chronic kidney disease, you will have two things. First, you will have a lot of phosphorus because you cannot secrete all this phosphorus. Second, you will lose vitamin D, or you will lose the active form of vitamin D because you usually activate it on the kidney. Okay. Now, when you have a lot of phosphorus, you will have high parathyroid hormone because parathyroid hormone will hit the phosphorus. Okay. When you lose vitamin D, you will have low calcium, right? And you will also lose calcium because you cannot reabsorb it in the kidney. When you have low calcium, you will also have high parathyroid hormone. So secondary hyperparathyroidism will usually be high phosphorus, low calcium, low vitamin D, active vitamin D, and a high parathyroid hormone. Okay. Now this is difference in tertiary. Tertiary happens years after chronic kidney disease, and in tertiary the only difference is that this calcium will be high finally, because the constantly high parathyroid hormone will ultimately increase calcium secretion from the bones, so it will cause increase in the calcium, and this is called tertiary. Okay, so the only difference between secondary and tertiary is that calcium will be high in tertiary and low in secondary. Okay, here I said low in tertiary, just edit it. Okay, edit it. Okay. Now, the most common cause of hypoparathyroidism is when you remove the thyroid gland. Sometimes you can remove the parathyroid gland by mistake. Okay. Now, if you have decrease or constantly low hypocalcemia and the hypokalemia that's not responsive to treatment, then you need to suspect that there is low magnesium. Okay, because usually magnesium is important to increase the parathyroid hormone sensitivity. So if you have low magnesium, you can have low calcium, sometimes also low potassium, that are unresponsive to treatment. Okay, now when you see an African American woman, middle-aged, present with cough and bilateral hilar lymphadenopathy and high calcium, you suspect a disease called sarcoidosis. Now, the reason sarcoidosis will cause high calcium, because we said sarcoidosis has granuloma on it, right? Now, granuloma has specific cells called the histiocytes. These histiocytes have activate an enzyme called 1-alpha hydroxylase, which will activate vitamin D, which will increase calcium. Okay, so that's why sarcoidosis will always present with high calcium. Okay, now this is here is exophthalmos, which you see in Graves' disease, and exophthalmos usually happens from inflammatory mediators here, like glycosaminoglycans, and many inflammatory mediators. So the only way you can treat this patient condition is either by surgery or by giving anti-inflammatory medication. Now, what's the most important anti-inflammatory medications? Steroids. So steroids is the only medical treatment for exophthalmos in Graves' disease. Another thing is that beta blocker is cardioprotective in thyroid storm. Thyroid storm happens when there is usually increased surge of the thyroid hormone in the body. Okay. Now, both of them can decrease thyroid level by inhibiting 5-deiodinase, which is the peripheral deiodination of T4 to T3. Okay. Now, whenever you see a hyperpigmented skin and abdominal pain and the low blood pressure and the hypoglycemia and the eosinophilia, this is usually Addison disease, which is autoimmune destruction of the adrenal gland. You will lose cortisol, so you will have hypoglycemia and low blood pressure. When you lose cortisol, you will have high eosinophils because cortisol is anti-inflammatory. And also when you have high ACTH, you will get hyperpigmentation. Okay, this is important. So the reason you get hyperpigmentation is that you will have high ACTH, and the reason you have high ACTH is that you will have high something called BOMC. This BOMC will increase melanocyte stimulating hormone, which will increase melanin, and that's why you will have hyperpigmentation. Okay, now BOMC will also increase endorphins, which are painkillers, endogenous painkillers, and sometimes they will ask about endorphin also. Okay. On the other hand, when you see abdominal stria, easy bruising, hyperglycemia, hypertension, this is called Cushing syndrome. And the Cushing syndrome is high cortisol hormone in general. Okay. Now it can be caused by a lot of things. It can be caused by Cushing disease. It can be caused by lung cancer. It can be caused by taking cortisol from outside, which is the most common cause. So there is a lot of causes of Cushing syndrome. Okay. Now the reason high cortisol the reason high cortisol, or sometimes they will ask you what high cortisol does, is that it will decrease all inflammatory cells but increase neutrophils. The reason it increases neutrophils is that it increases neutrophils migration. So if this is neutrophils here, they usually sit in the blood vessel like beds, okay? And what cortisol does is that it will trunk them and it will increase them in the blood vessel itself. So they will increase neutrophils in the blood vessel, okay? Okay. So the causes of Cushing syndrome can be exogenous steroid intake. Now, when you take steroid from exogenously or cortisol exogenously, you will have low cortisol in the body and low ACTH, because the corticosteroids that you are taking from outside are different from the corticosteroids you are taking from inside, okay? So the cortisol itself, which is the endogenous hormone, will be low. ACTH will also be low, okay? Okay. Now, another cause is adrenal gland adenoma. So you have adenoma in the adrenal gland that secrete a lot of cortisol. So you will have high cortisol, but you will have low ACTH by the negative feedback. Okay. Now this one will not be suppressed by high dose dexamethasone. Now, small cell lung carcinoma can also cause Cushing syndrome because it can secrete a lot of ACTH. So you will have high ACTH, you will have high cortisol, but it will not be suppressed by high dexamethasone also. Okay. And you will see hyperpigmentation. Pituitary adenoma can also secrete a lot of ACTH, and this is called Cushing disease, and you will see high cortisol, high ACTH, but this one will be suppressed by high dose dexamethasone. So if you need to differentiate between them, pituitary adenoma is the only one that would be suppressed by high dose, okay? The difference between a small cell and the adrenal gland is that in a small cell lung cancer, you will have high ACTH, but in the adrenal gland, you will have low ACTH. And the both of them will not be suppressed by high dose dexamethasone. Okay. So sometimes they will ask about the paraneoplastic tumors. So you need to know that the small cell lung cancer secrete ACTH and secrete antithyroid hormone, and it can cause Lambert-Eaton syndrome, and it can cause cerebellum dysfunction by antibodies called anti-Hu and anti-U. Okay. Now, squamous cell carcinoma, on the other hand, will increase the parathyroid hormone-related peptides. So it will increase calcium and decrease phosphorus. Just remember squamous calcium, okay? Now, parathyroid hormone-related peptide is different from the normal parathyroid hormone level. So in a person with a squamous cell carcinoma, you will have high parathyroid hormone-related peptide, but you will have low parathyroid hormone itself, okay? Now, another important concept is that autoimmune disease, specifically in the endocrine, they usually come together, okay? So usually you will see type 1 diabetes mellitus, which is autoimmune. You will see pernicious anemia, which is antibodies against the gastric mucosa. You will see vitiligo. You will see Addison disease. You will see Hashimoto thyroiditis. All of these are autoimmune problems in the thyroid gland, in the adrenal gland, in the skin, in the stomach, in the pancreas, and they always come together. So they will give you a history of a person that have another family member, or this person itself has another autoimmune condition, and then they will somehow ask you about another autoimmune disease that come with it, okay? Now, Down syndrome increases the risk of all of these autoimmune conditions, and we have a condition called Ibex disease, or we have also polyendocrinopathy, and you will see a lot of endocrine conditions that come together in this disease, polyendocrinopathy. Okay. Now, another concept is that renal cell carcinoma or squamous cell carcinoma of the lung. They secrete parathyroid hormone-related peptide, which is different from the endogenous parathyroid hormone. So you will have high calcium, low phosphorus, high parathyroid hormone-related peptide, and the low parathyroid hormone itself. Okay. Another important concept is to know the function of aldosterone. So aldosterone usually absorbs sodium and secrete potassium and secrete hydrogen. So if you have Cohn syndrome, which is an aldosterone secreting tumor, you will have high sodium, but you will have low potassium and low hydrogen. Low hydrogen equal alkalosis, equal high pH, equal high HCO3. This is all the same thing, okay? On the other hand, when you have Addison disease, which is autoimmune destruction of the adrenal gland, we discussed it before, you would get low sodium and the high potassium and the high hydrogen, which is acidosis, which is low pH, which is low HCO3, okay? Okay. Now the next concept is bilateral congenital adrenal hyperplasia. So this is usually a congenital problem, and it's usually a problem in one of the enzymes that are used to synthesize steroid hormones. Okay, now you have three variants of this bilateral congenital adrenal hyperplasia. You have either 21, either 17, either 11 alpha-1 hydroxylase deficiency. Okay, now in the three of them you will have low cortisol. This is important, but the difference is the sex hormone and the aldosterone. So the way I remember it is that 21, when you are above 21, there is a lot of sex, right? So 21 will have a lot of sex hormone but low aldosterone. So you would see, for example, in females, virilization, things like that, right? And because you have low aldosterone, you will have low sodium, high potassium, and acidosis. And the low glucose, of course, because low cortisol. On the other hand, in 17, you are less than 21. So you will have low sex, but you will have a lot of aldosterone. So you will have high sodium, low potassium, and alkalosis, and low glucose, because you don't have cortisol, and you don't have, and you have a lot of aldosterone. Now in 11, on the other hand, I remember it by 1-1. You have two things, 1-1, okay? So you have high sex hormone, and you have high deoxycorticosteroids, which will do the same function as aldosterone. So you will have a lot of sodium, you will have low potassium, you will have alkalosis, and you will also have a lot of sex hormones, okay? Now sometimes they will give you a laboratory value. When they say there is 17-OH substrates, or dihydroaldosterone, or androstenedione, when they say they are low, it means that sex hormones are low. It means it's 17-OH deficiency. But if they say it's high, it means sex hormone is high, and it's either 21 or 11 deficiency. Now the way I remember it is I remember anything that has andro on it, or brig on it. So andro and the brig, I know they are sex hormones. Okay, so if they tell me these things are high, I know I am talking about high sex hormone. So I know I am talking about either 21, usually 21 or 11, because 21 is the most common disease out of them. Okay. Now whenever you see episodic headache, palpitations, and the hypertension in a person, this is always pheochromocytoma. And you treat pheochromocytoma with phenoxybenzamine, which is an irreversible inhibitor of alpha-1, okay? So it's irreversible alpha-1 blocker, okay? And you always give it before surgery and never give it after beta blocker. You always give it first, then you give beta blocker. If you give beta blocker first, you will kill the person, because this person have a lot of epinephrine, and they are activating alpha-1, and they are causing extreme vasoconstriction. So you need to relieve this vasoconstriction. That's why you need to give alpha blocker, okay? The next concept is that insulin has two N's on its name, N. So we know it make two things go inside the cell. The first thing is glucose. It will make glucose shift from plasma to inside the cell. The second thing is potassium. So we know that insulin will cause hypoglycemia and hypokalemia, okay? Another thing is that insulin is anabolic, so it builds things. So it will build the glycogen. It will cause glycogenesis. Genesis means synthesize. It will cause lipogenesis, building lipids, okay, by something called the lipoprotein lipase, okay. It will cause protein synthesis, but it will inhibit gluconeogenesis. Gluconeogenesis is breaking down all these things to make glucose. It will inhibit it, okay. Now all the other hormones will do the opposite of insulin, and the way you think about it is that insulin will literally fight all the other hormones. So any other hormone will do the opposite of insulin. So for example, glucagon will do glycogenolysis. Glucagon will increase gluconeogenesis. Glucagon will inhibit glycogenesis. It will inhibit protein synthesis. This is the way you think about it, okay. Now in the drugs of the diabetes mellitus, you need to know that metformin can cause lactic acid, and don't give it in renal failure. Okay. Another thing is SGLT2 inhibitor. It will inhibit the absorption of glucose in the urine, so it will make it secrete in the urine. Now when glucose is secreted in the urine, yes, it will decrease in the blood, right? So this is great. This is how it can treat diabetes mellitus. But when it's very high in the urine, then the infectious organism will eat it, and when they eat it, they will grow. So it will cause growing of the infectious organism. So it can cause urinary tract infection, and it can cause candida, okay? So this is important. So SGL2 inhibitors will cause urinary tract infection and the bacterial vaginosis, candida, okay? Sulfonylurea, on the other hand, is another diabetic drug. It will inhibit something called ATP sensitive potassium channel in the beta cells, and when they inhibit it, they will increase calcium in this cell, and they will increase insulin secretion, okay? So this is how they increase insulin secretion, okay? Now when they increase insulin secretion, they will also increase something called the C-peptide, which is usually secreted along with insulin, okay? The next drug is called TZD, and this drug stimulates the bar gamma, and it will increase insulin sensitivity, and it can treat diabetes mellitus, meaning it can treat hyperglycemia. Now this is opposite to something called the fibrates, which activate the bar alpha and treat hyperlipidemia, specifically triglycerides, okay? Now you need to know that TZD, it can cause a little bit of heart failure, and it can also cause edema, okay? But fibrate can cause gallstones, and it can cause muscle problems, myopathy. Remember we said never give fibrates with a statin, because both of them can cause myopathy, okay? Now another thing is the difference between type 1 diabetes mellitus and type 2. This is the difference here, but I need to highlight that type 1 happens in young people, right? So it's an autoimmune problem. So you would see lymphocytic infiltration, you would see antibodies, okay? Type 2, on the other hand, happens in old people. So you would see amyloid deposition, okay? This is how I remember it, okay? Now another thing is that because type 1 is autoimmune, it's associated with HALA, because HALA is usually associated with autoimmune conditions, okay? So it's associated with HALA DR3 and DR4. Type 2, on the other hand, is more familiar than type 1. So if you have a strong family history, then you have a strong predisposition to type 2, not type 1, okay? Another thing is that we have two conditions that can happen after type 1 or type 2. The conditions that happens from type 1 is called diabetic ketoacidosis. The conditions that happens from type 2 called hyperosmolar hyperglycemia, okay? The most important difference between them is that diabetic ketoacidosis will have glucose levels that's not that high. It's about 250. But hyperosmolar hyperglycemia will have very high blood sugar, which will be more than 600, okay? Another important thing is that this is called diabetic ketoacidosis. So you will have ketone bodies that will cause high anion gap metabolic acidosis. You will have ketone bodies that will cause high anion gap metabolic acidosis, okay? Now when you have a lot of acid, your lung will try to get rid of this acid as CO2, so the person will breathe too much, and this is called the coastal respirations, okay? So you will see coastal respirations because the lung are trying to compensate. The lung is trying to decrease CO2, so the lung is trying to increase the respiratory rate, okay? Now the symptoms of DKA will usually be vomiting, nausea, and abdominal pain, very important. But the cause of hyperosmolar hyperglycemia is profound dehydration, okay? And the next concept is that ghrelin will make you hungry, but leptin will make you full. And it makes sense. So ghrelin is usually secreted from the stomach when you are hungry, when the stomach is empty, okay? And it will increase the appetite. Leptin, on the other hand, is secreted from adipose tissue. So if you have a lot of adipose tissue, it means you eat it a lot, right? It means you have a lot of stores. So you will have decreased appetite, okay? And this is important. So you always have this balance between ghrelin and leptin. This is very important, okay? And the last thing, it's not a concept but an advice, is that they are always obsessed about arrows question, which increase, which decrease, what iron increase, what iron decrease, whatever, okay? So I always need you to spend some time understanding the function of each hormone, not just memorizing it, because sometimes they will give you a weird disease you never heard about, but they will tell you, for example, oh, and in this disease, parathyroid hormone is high, but it's not doing its function or whatever, okay? So that's why you always need to remember that you need to understand first what happens, then memorize it, okay? So memorization usually come after understanding, okay, guys? And this is it. Thank you for watching, and see you in the next chapter. Bye bye.